is a good time for me to do a little promotion because I am at CU Denver, but on the downtown campus. I also do some clinical work at National Jewish, which is how I met Dr. Fisher. But we have a doctoral program in clinical health psychology on our downtown campus. So Denver is becoming infused with a lot of great health psychologists. So just to know that they're out there, and in Colorado in general. But the way that clinical health psychology differs from traditional psychology is that we are very focused on working with medical patients, their families, caregivers, and helping people adapt to chronic illness and adjust to that. So very different than sort of the typical psychologist who's focused on specific mental health conditions. So certainly people who are dealing with chronic illness are going to experience depression, anxiety, some of the things, a lot of grief and loss are a lot of the things that we tend to work with, but definitely with a focus on trying to understand the medical issues, the medical symptoms, because as many of you may know and have experienced, there's a big overlap oftentimes between, for example, symptoms of depression and a lot of the symptoms that you may be experiencing associated with your chronic illness. So, for example, things like fatigue, changes in appetite, changes in sleep, decreased motivation and energy. All of these things are symptoms of depression, but also are oftentimes manifestation of different types of chronic illnesses. So that's a little kind of a brief overview. In terms of, as I said, as a health psychologist, certainly we can work with people who have kind of the standard depression and anxiety, which again is very common, especially common with autoimmune disorders. And I'm not sure if we know it's sort of the chicken or the egg, what comes first, but I'm sort of surprised when I see someone who has an autoimmune disorder and has not ever had any problems with their mood. Okay, we know that oftentimes there's problems with sleep. We talked about energy level, and again, big overlap with mood disorders. And the same idea, we know anxiety is also very common in people who are suffering from different types of medical illnesses for a variety of reasons. So there are a lot of great interventions we can do to help manage anxiety. As a health psychologist, most of the therapy that I do is cognitive behavioral therapy, which is very evidence-based, especially within the field of health psychology. Some existential psychotherapy, but not the type of therapy. You won't find a health psychologist who's going to have you lie down on a couch and talk to you about their dreams. So I always say that people have this fear sometimes of coming in, and that's not the kind of therapy that we tend to do. As health psychologists, we also work a lot with health behaviors, so helping people with their health behaviors, things that we know that may be helpful for them, not only for their physical health, but also can improve mood, right? So we know things like activity, getting outside, we know diet, nutrition, getting good sleep, all of those things are going to have an impact on both physical and emotional health. And, as a health psychologist, I don't prescribe medications. I'm not a psychiatrist. I'm not a physician. I leave that to my physician colleagues. But I feel strongly that emotional health is very much linked to physical health. So if we can help improve your emotional health, it's probably going to have a positive impact on your physical health also. Just a couple of things I wanted to say. And I've talked here before, so some of you may have heard this before, but some of the things that we know from the research in health psychology that are really important. One is social support, okay? And I always say that with social support, it's not quantity, all right? You can have 1 million friends, but do you have friends that can provide emotional support, practical support, and tangible support? Okay, so it's really more about quality than quantity. We know that when we talk about coping skills, it's really important, and some of you may have seen me talk about this in the past, being able to distinguish controllable versus uncontrollable stressors, because once you determine that, it's going to impact the types of coping strategies that you can use. And I always like to talk about this a little bit when I'm working with people that have autoimmune disorders, because we actually have, there's not a lot of health psychology research or psychosocial research specific to autoimmune disorders, and certainly not scleroderma. But the research that has been done has been very interesting in that it's what's consistently come out is having an outlet for your, emotions. So we think of this as emotional expression. You could do this in all kinds of ways. Some people like to journal. Some people use it through music or artistic endeavors. For some people, it's having people to talk to. But having some ways to get some of the emotions out, it could be meditation, prayer, all of those things seem to have a positive impact on symptoms. So there have been some really interesting studies, again, not specifically scleroderma, but with rheumatoid arthritis and some other autoimmune disorders. So that's something to think about. You don't want to keep those emotions just inside. You want to find some healthy ways to channel those out. And I'm happy to talk more about ideas for that if you're interested. Let's see, I wrote a quick little thing. Hobbies and interests. So one of the big challenges when you're living with a chronic illness is oftentimes you have to make changes to your life. And sometimes it may be hobbies and interests and things that you enjoy doing you're not able to do to the full extent that you've been able to do in the past. And so we really encourage people to work on not giving those things up, but thinking about how you can make changes to that. If you have a love of, let's say, bird watching or something like that, but you're not able to just go out there like you used to up in the mountains and do all of that, there's still ways that you could connect to that. And that's really, really important in terms of how you learn to live with your chronic illness. What we really don't want you doing is giving up things that you used to love and not at least replacing them or changing them with new things, okay? Because then what happens is you become you kind of lose your sense of identity and who you are, and your identity becomes your illness. And that's not good. We don't like that. So keeping things in your life that are separate from your health, that you enjoy, that bring you joy and you're passionate about are really important. And the other thing I want to touch on, and this is actually an area that I'm really interested in, and I've done research in this area, not as much with autoimmune disorders, but I also do research in oncology, is this idea of positive benefit finding. And I don't know if any of you have experienced this, and sometimes when you're early on in your illness and it's kind of new to you, sometimes it's hard for people to imagine this. But there's some very interesting research, and I see it clinically all the time, in that, and it comes from the trauma literature. So in experiencing trauma, very difficult, challenging times, which definitely any kind of serious medical illness is going to challenge you in many ways that you've probably never been challenged before. From that challenge and those difficulties, there can be tremendous potential for positive changes, okay? And I see this a lot in the people I work with. So as difficult and as hard as it may be, from that, people often make big changes in their life. It could be related to work or relationships, or they take up that hobby, or that they go travel to that place they always wanted to go to. So I think there certainly are some positive benefits that can be gained. Not that you would ever want to have to go through this process and illness to get those gains or those benefits, but certainly there is a positive growth that I see in a lot of people who are dealing with these types of challenges. So I probably talked enough for right now. Maybe some of you now have some questions that you're interested you wanted to ask related to any of this, or Dr. Fisher's here too, so if you want more general medical. Nothing? Yes.
I don't really have a question. I suffer from a chronic disease. Mine is mental illness, but one of my best coping skills is humor.
Mm-hmm. That's
and
great, yeah.
you didn't mention that, although in some ways it goes with the trauma. But I think anytime you have a chronic illness, it is a trauma because your whole life changes.
Mm-hmm. Yeah, and humor is definitely on that list of emotion-focused coping strategies, so thank you for bringing it up. And it can be very, very beneficial for people. Yeah, exactly. And there's been some nice studies looking at that, the positive benefits on physical health as well as emotional health. Yes?
Well, just about, what's the
So the question is, yeah, I'll call. You all can hear me, right?
Yeah.
Yeah, so the question that Bobby is asking is patients who have the combination of interstitial lung disease and pulmonary hypertension, how do we know if they rely on their own oxygen or maybe even what's driving what? And that's difficult. And so that's whereby we really need to have multiple specialists involved quite often, interstitial lung disease assessments, pulmonary hypertension assessments. We're looking at radiology studies, we're looking at echo studies. Sometimes we have a hard time teasing out what's driving what. And sometimes we're treating both and just continuing to assess each in their own capacity, and doing our best to sort that out. But it's really challenging. It can be really challenging. Yes.
Dr. Kilbourn about the neck, but so many people have dementia now, and limitation of oxygen supply is very bad, or maybe some of the problems.
I don't remember the specific context. I can tell you that we access the pulmonary circulation through the vein in the neck. That's how we do the right heart catheter.
I can add to that. I mean, I don't know a lot about it, but certainly I think a lot of people with autoimmune disorders, as we also see in oncology patients, describe sort of a brain fog that they experience that often goes along with some of these other symptoms like high levels of fatigue and things like that. So there are different kinds of things we can help to do to look at that, at least from a psychosocial aspect, to help with that piece.
So the question is, at what point do we do a right heart catheterization? For those who in the audience have had one, they would know that it's been done when we think that the patient may have pulmonary hypertension. It's the only way we can make that diagnosis. So if we have a scenario whereby we think the patient has pulmonary hypertension, a right heart catheterization is needed to confirm that. I'm going to interject a little bit because I don't get a chance to share the stage with Dr. Kilbourn that often. And thank you for doing this. One of the things that I know that I have many shortcomings. One of them is, sort of understanding the patient perspective, maybe understanding, what it is that really changes with this diagnosis and how globally this impacts patients. And so I kind of feel that we underutilize clinical health psychology, mental health providers, and we don't do a good job in traditional medicine. Time, we're not the right providers, maybe we don't know the right questions, of really getting to these other aspects, right? We talk about the skin, and we talk about Raynaud's phenomenon, we talk about pulmonary hypertension, interstitial lung disease, the gut, the whole day, right? That's what we did. Meanwhile, we really forget, how impactful the rest is on our patients. And so, I don't know, I kind of want to take advantage of your expertise here and, maybe giving someone like me advice on how to access or, how should we be interacting, or should this be on a checklist? I talk about getting a high-resolution CT scan. Should we also be getting a psychology evaluation?
Mm-hmm. Yeah, I mean, certainly that would be the ideal. if we could control all of that. I will say at National Jewish, so for example, the work I do at National Jewish, I do a lot of work, and Michelle also sees a similar population with the infectious disease. So I see a lot of infectious disease folks there, and we actually have it set up so that they get a health and behavior consult every single person who comes in. And that's one of the myths I always want to dispel in terms of the type of work that I do, that you don't have to be coming in super depressed or really, really anxious to benefit, even if it's just a one-time consult, because typically in my consults I give a lot of ideas and information, things that are things that I can tailor specifically to the person I'm working with, but you may find helpful from just that one visit. So it doesn't mean necessarily that if you see someone like myself or a health psychologist that it means that you're really having a difficult time coping or a hard time. Oftentimes people who are even doing well, I can reinforce the things that they're doing well and maybe get them to think about other things that could be helpful for them. And oftentimes even just to let people know that we're here. So if down the road you start to have a hard time either adapting to different kinds of symptoms or things like that, you know that there's someone that you can go in and talk with.
What about couples visits?
So the question was, what about couples visits? Great question. So the majority, probably most of the time when I see folks, at least for initial consult, it's often with, could be a partner, could be a caregiver, family member, could be a really close friend. So oftentimes we will incorporate partners or caregivers into it. Sometimes it can become more of a formalized sort of couples therapy, and sometimes it's more to have those other people there as support, so they can also benefit from learning some things that might be helpful for their loved one. I also do a lot of research with caregivers, so that's a particular interest of mine. As you probably know, caregivers don't get a lot of attention right now. We're trying to change that and have more programs available specifically to caregivers, because what tends to happen with caregivers is that they put so much focus on taking care of their loved ones that they often neglect their own self-care and are then at their own risk for health problems, emotional and physical.
I was just thinking that when you're running into the hospital, you need to see a doctor, and they tell you, okay, if you're on your life, you know, because you don't have long to live, and you
Right, and that's a really, so the question was that oftentimes you may see someone and they give you a diagnosis, a life-limiting diagnosis, or may say, you know, you only have so long to live, or this something related to that, and then you kind of feel like you don't know where to go to get support. So oftentimes that's the kind of thing that we can also help you with, is that adjustment. As I mentioned, a lot of my work also revolves around grief and loss, and not necessarily end of life, although that's part of it, but even just grief and loss around not being able to do things that you were previously able to do, having to make those kinds of changes. A lot of grief around suddenly my body's not working the way it's supposed to, and that's really hard. So that's certainly a theme to a lot of the work that I do.
Bobby, you've proven them all wrong.
Yes.
Do you have an office in the Springs, or are you just strictly in Denver?
I am in the Denver and Golden area, but I may be able to help connect you with some folks down there in the Springs if that's of interest. Certainly. I should say I should give a little another little promotional thing. For those of you who are in the Denver area, we have a clinic down on the downtown campus, the Aryeh campus, right on Spear and Larimer, if you're familiar with the CU Denver campus. And we have a clinic there where we train our doctoral students. I'm one of the clinical supervisors. And remember, this is a clinical health psychology training program. So we actually love to see, and we have community members are welcome. We love to work with people who are dealing with illness issues or are caregiving for someone with illness issues. And it's a very reasonable, we don't take insurance, but it's all sliding scale. People pay as little as $5 a session. So that is something just to know about. And I think we have some information. I'll talk to Cindy, but maybe we can post some more on the website if you're interested. But a really good resource, because I know one of the big barriers to being able to get mental health or be able to see a health psychologist is the insurance piece, sadly. So it's nice at least to know that there are places where you can go where.
So I'm gonna ask Kristin to correct me or to redirect me if anything I'm saying now is off base. So here's how I look at this a little bit. I'm supposed to be a scleroderma expert, okay? I don't have the time or the expertise to be able to counsel on all the ways that you're going to have to, and your caregivers are going to have to adapt, how you're going to adjust to this new reality. You've been given a label, quite often a diagnosis that doesn't make any sense. It's a skin disease. You tell your family you have a skin disease, and they're telling you, yeah, they also have eczema. We have in society an understanding of how devastating a disease like cancer is, and that'll almost stop the conversation, and yet this can be worse than cancer, and people don't really know that. And it impacts you all in ways that I couldn't even imagine. So then I look at it and say, how am I'm supposed to be doing all this scleroderma stuff, but yet I'm missing so many fundamental aspects of how the disease impacts you, your loved ones, and your life. And I'm not talking about mental illness, right? I'm just sort of talking about mental health.
Right.
So that's where I would say, and for those patients who do see me, you can remind me this next time that I see you of this shortcoming, and how are we going to address that? And so that's where I think we need to come to a place on our side, sort of the scleroderma, care side, that we have to incorporate sort of mental health care, and we don't. So I don't know. I'm not really asking as much of a question as much as kind of a comment about our shortcomings and our limitations, and yet also trying to dispel the notion that going to see a mental health provider implies that there's a mental health problem.
Mm-hmm. Exactly. I think that's a really good point. I mean, part of this issue has been some of it's systemic, things that we have no control over, like this sort of, cutting off here, there's the brain, and then there's the body, and how insurance covers it, right, which has been crazy. So there's some issues around that have to do with why we're not more integrated, but certainly there is more progress being made in that area where we're trying, especially in primary care, for example, trying to do more integrative work. But I agree, that's always the message I'm trying to promote is that, just going in and talking to someone about your adjustment or the challenges that you're facing can be very beneficial. It doesn't mean that there's no stigma attached to that you have some kind of mental illness or it's embarrassing or you shouldn't need this or you shouldn't have to do this or what does this mean if I have to go talk with someone about this? Because it's really hard, and I agree with Dr. Fisher. Autoimmune disorders in particular, and scleroderma being one that's not that's more rare, that's not as common within the autoimmune disorders, it's very difficult because people don't understand it either. Right? So oftentimes when people can look at you and say, well, you look fine, so why are you saying you can't make it to this dinner tonight or to this event that we've been planning? Right? It's hard for people to understand what that's like when you don't feel well and you can't always predict how you're going to feel a week from now, a month from now. Right? They don't understand that. Our society's sort of based, people know kind of that model of you get sick, you get treatment, hopefully you get well, or you don't get well. But they don't understand sort of that chronic, what it's like to live with a chronic illness day to day. So part of that is educating them and figuring out how to talk about that, but also being able to get support from professionals who are separate from your social support network that may be able to help you with that. Yes?
Comment. I don't think we deal enough in this society about that. I mean, doctors are taught to heal. We aren't taught to help people die. But, we're all none of us get out of here alive, And so, to me, teaching about our health is teaching a whole continuum. We celebrate having babies, but we don't really celebrate the end of life, which some cultures do.
Mm-hmm. Yeah.
And I think that medical students don't get that training either. So,
Although I will put in another plug, we do have a great palliative care team here on the medical campus, both from the standpoint of clinical work and research. And when I say palliative care, I also that doesn't necessarily mean end of life also. So palliative care can be helping with pain management, fatigue, but right, it's all should be palliative, but also some great folks here that work with those end of life issues. I agree, that's really important.
all of us should be working this.
Yeah.
I missed the very first part of your introduction. Did you post how to contact you and how to contact your services?
I'm trying to think, do we have... I didn't have slides, so I don't...
Through the Scleroderma Foundation, Cindy has all of our contact info.
Mm-hmm.
We're happy to open this up to questions, both related to Dr. Kilbourn or anything else that was discussed today.
Actually, question for Dr. Kilbourn. Being in the office, and maybe this is a question for supportive leaders too, when we get calls from people that are newly diagnosed, so they're taking that initial step, but I think, I've heard from your previous discussions, the 5 stages of acceptance. I really think we're in the denial stage, and I personally feel that there's a lot of them in seeking the help that they need, and maybe further with Dr. Fisher, Dr. Kilbourn, and they just got a million excuses to not get across town or whatever to see them and seek the care. Do they just have to go through that process, or is there some way to help people through the denial stage to get them to seek treatment?
Yeah, so the Cindy's question was related to kind of why people, especially who are newly diagnosed, sometimes have a really hard time mobilizing and getting to the right physicians and utilizing the resources that are available to them. And it is a complicated question. Certainly, denial and avoidance. I always say denial is not necessarily a bad coping strategy in the short term. Right? In the long term, it can be problematic. So sometimes there is that process of where someone's just trying to assimilate and adapt to this idea of suddenly, your whole life has changed. The life that you thought you had set out in front of you, or what we all tend to kind of think of this controllability that we all sort of fantasize that we think we have, although I don't want to scare you all, but the reality is we really don't have that much control over things in our life. But we like that gives us comfort. And when suddenly we're diagnosed with some serious illness, it's suddenly we have to deal with that. Like, wow, the world isn't as safe and predictable and controllable as I always thought it was. So sometimes it's easy to go into that sort of avoidance denial for a bit because it's just too overwhelming to really think about that. And most people usually can kind of go through that process in a few days or maybe a couple weeks. But when it becomes a problem is when they're sort of stuck there. And so I think in terms of when those people are calling in, maybe part of that is acknowledging that that's normal in the short term, but in the long term it can be a problem because it is keeping them from getting to the resources that they need that could actually benefit their health physically and emotionally. Hope that's a good answer. It's a tough one.
Just maybe hit on that concept in general of driving across town. And this is not a convenient disease, and that's, to put it lightly. And we're not here to try to make it more complicated. One of the reasons, and I know there are people who travel a long way to be here today, we would advocate for even just a once-a-year type scenario whereby we allow patients, access to Scleroderma, experts, so to speak, that will work with local teams. And it allows us to enroll in our clinical database, research database, so if clinical trials become available, we can then access patients. We want to try to make it, work so that it's, kind of almost demystify this visit to the University of Colorado, which is not convenient. Parking is a problem. We hear about all this, we're hard to reach, etc. But the idea would be on our end, we would like to be able to be a resource for this region. And in Colorado, that's a pretty big statement because it's not just Colorado, it's Wyoming, it's New Mexico, and it's parts of Nebraska, Kansas. And so for those who traveled a long way, for those who come and travel a long way to see us, we want to try to make it work for you all to the best of our ability. So it may just be like a one-time-a-year visit. So Sydney, when you're talking to the patients who maybe are in different phases of denial or hopefully acceptance, we want to try to make it work for them. And so I know the patients who are here who have traveled a long way, we do our best to try to make that work so that we're a resource and not kind of get in the way of local care, but hopefully enhancing local care.
Well, what would be a really cool idea? This is what we're doing a little bit in the work I do with cancer, some of our clinics for young pediatric cancer survivors who are now adults, but is more of a multidisciplinary, once-a-year clinic where you guys could come in and you see all these different experts, from the physicians to the nutritionist to the psychologist. That would be a really great model.
And we do that for some of the stuff that we're better at, right? Mm-hmm. So we'll do that for the lungs and for the gut. We've struggled, and I'm curious, maybe a little segue, just from a financial, insurance coverage. I know you addressed it and how you handle it on your downtown campus. Getting coverage for these kinds of appointments, we've had a hard time with, and I don't know if people in the audience have had that same problem, just getting a visit covered. We aren't able to get nutrition covered. So
yeah, we've actually had to go get funding from the state and outside to help cover some of that. As a psychologist, I can use health and behavior codes, so most insurance covers that nowadays. But
your model is exactly what we should be striving for.
Mm-hmm.
Is there any thoughts on like video chat for issues like dealing with the changes in life that you're going through and the stress that causes with couples and families?
So the question was, can you use video chat or something similar to that to help with that? Yeah, certainly. Yeah, there's still a few issues. There's issues if it's out of state because of licensure and things like that, but there's certainly, we have been doing some work mostly focused in oncology and with caregivers, but using Skype, using web-based kinds of things that can help deliver interventions to people who are in remote or rural areas. So there are a lot of things that are available or kind of coming on soon.
Your chat rooms, it's a lot of places for that.
Mm-hmm.
Yeah.
Well, I've actually been trying to see for a while. My insurance doesn't cover it. But my question was, what do you do after you try everything that you listed for?
So the question is, what does one do if they've exhausted, the options that I had listed on my slide for interstitial lung disease?
And it's still progressing.
I'm sorry?
And it's still progressing.
And it's still progressing. Well, I didn't talk about lung transplantation, and I don't know your case, and so I don't mean to impose. I can't project on you as to what you might need or not need. But lung transplantation is the definitive treatment when medication therapy is no longer an option. And lung transplantation, even if there is right heart involvement from pulmonary hypertension, typically the heart does not need to be transplanted. Typically it's just a lung transplant, and then with that new lung, actually the pulmonary hypertension resolves as well. So the treatment for advanced pulmonary hypertension or the treatment for advanced interstitial lung disease that has been progressive despite therapy is lung transplantation. And it's not a simple process. I'm not a lung transplant expert. I do work with a lung transplant team here, and sometimes it's difficult to get a scleroderma patient accepted for lung transplant because at least at this center, some other centers, the experience has not been as favorable. And it's all about trying to do the best thing for our patients and not to harm them. And so if there's a concern that the transplant wouldn't be successful, I would understand why there would be reluctance. That being said, there are centers that have more expertise than others. We send our patients to University of California in San Francisco. We send them to Los Angeles. We sent them to Duke. We sent them to Pittsburgh, to programs in Arizona and in Texas. And each one is individualized and tailored according to the patient's specific needs. That's not a simple process because it does require some degree of relocation. But if the treatments are not working, and that's unfortunately not that uncommon, if patients are still progressing, we pursue lung transplant as an option. We don't give up just because the medications didn't work.
Yeah, I'm trying, my insurance is trying to get me to know right now. So well, it's not transplant, right?
And I'm happy to talk to you after this, and we can have more of a conversation about your specific needs, because this center is a little bit reluctant to transplant scleroderma patients. So we should have that conversation off. Okay?
So mine is totally out of what we've spoken about today. I think he had suggested surgery, 10-minute realignment, that sort of thing. And I am really willing to go that way because I already know how hard it is for my skin and my fingers and stuff to heal. So I'm worried about internally. What are your thoughts on that?
I understand, your concerns without knowing your specific, scenario. I mean, I would say we want, the surgeon to be aware that the patient has scleroderma. That's sort of step one. And truthfully, from a surgical perspective, the biggest issue is making sure that we know what the heart and lung are doing to make sure the patient can get through a surgical procedure safely. And pulmonary hypertension is the biggest obstacle in that regard. So that's sort of issue number one. Now the issue is tendon repair could be no problem at all if that involvement is not around the site of operation. And so I would encourage my patients who are having orthopedic issues that need to be addressed to have them addressed and just let the surgeon know what we're dealing with. And usually it would entail some communication between the orthopedic surgeon and the scleroderma doc to know what we're getting into. Cosmetic procedures are more problematic. Some people are not maybe thrilled with the change to the facial features and telangiectasia, and can we do something about them cosmetically? And that's the scenario whereby we just want everybody to turn the lights on, have the conversations, and go into it with a full set of details related to what are my potential risks, what are the potential benefits, how is this disease going to impact my likelihood of success. For what you described, I would say I don't think scleroderma gets in the way at all with regards to repair. That being said, how involved is your knee from a skin perspective, and that might impact. But there has to be crosstalk, between providers in that area.
Any relationship or statistics showing up relationship between scleroderma and shingles?
We see shingles all the time, unfortunately. We see it unrelated to autoimmune disease. We see it unrelated to scleroderma. We see it as a process of natural aging. We all have gotten herpes infection when we were younger, right? Not the herpes that has the bad label, so to speak, but just it's a common virus. It's out there. We've gotten chickenpox, right? It's one of the herpes viruses. So we all have gotten chickenpox. And then as we get older and our immune system gets, weaker, chickenpox comes back, and that's shingles. We help that process, unfortunately, when we put our patients on medications that suppress their immune system. We see shingles all the time in our rheumatoid arthritis patients and our lupus patients that are on immune-suppressing medications. Scleroderma has many challenges. Shingles isn't one of them. It's just it's something we will see in our immune-suppressed scleroderma patients, or sometimes just our elderly scleroderma patients.
years ago when I'm Dallas County certified, we're that's part of the roads and population. Sometimes we have to have that safety used and black other pieces of tissue onto that portion where the blood vessel be attached. But we're just about that we could use
Sorry to hear about those problems for you. No, I'm not aware. I'm not aware of a linkage. Doesn't mean that it isn't out there. It just means that I'm not aware of that linkage. There are a lot of people who have pterygium, that challenging eye disorder, and I would predict that nearly all of those patients do not have scleroderma. And so sometimes there are associations that we're just not aware of. That may be the case, but I can't think of actually any of my scleroderma patients who have been counted out.
And I thought I'd ask something because I did classify my eye doctor as well. My rheumatologist is Dr. Kilbourn, but they did conversion outside of their good initiative in these forms because someone else may be experiencing it. And then the other thing that was very hard for me to tell was I told what I thought was that I think it actually, when you get very tired and my eyes are still in my eyes, what you love for a long time and you rest, it was actually the original cause of the
Thank you for that question because it kind of reminds me of the question about neuropathic foot pain that came up about 5 hours ago or so, or 4 hours ago. And it's a reminder of one of the challenges that you all face is trying to figure out what's related to your scleroderma or not. I can tell you that all of your other doctors who are not scleroderma doctors are blaming everything on scleroderma. We get that. We totally get that. And our job is to try to weed through that a fair bit. It's not meant to be flippant. It's not meant to be comical. It's meant to be, let's be clear about what this disease is or isn't doing. I mean, things like fatigue, things like impact on depression, things like impact on sleep and all that, I think are so challenging to tease out. But really, that's part of our job, working with other doctors, is to try to, hey, this is what this scleroderma is and isn't doing.
Is it safe to get dental implants with scleroderma?
Is it
safe to get dental implants?
safe? Yeah. So I think this goes right back, and we had a great dental, expert last year speak to us, and I actually email him from time to time when I'm asked dental-related questions. The answer is it can be safe. The bigger problem is the dry mouth syndrome, Sjogren's, that runs with scleroderma, and the challenges of that reality on the success of the implants. And then a lot of scleroderma patients, and as particularly women get older, they have osteoporosis or osteopenia, and the treatments for those conditions impact dental implants. There's nothing about scleroderma that challenges dental implants outside of those two realities. Maybe access to the back of the mouth with a smaller mouth opening can be a challenge also.
Since you're doing everything not related to scleroderma, I have one more thing. I've had cataract surgery for glaucoma, and now he says my glaucoma is coming back. So I'm thinking, is that related at all to any high pressure? I don't have pH. I'm 19 on that scale.
The only relationship would really be steroids if they're being used for the treatment of scleroderma, because steroids are a risk for glaucoma. But there's nothing about scleroderma that lends to a risk for glaucoma.
I also developed vasculitis in her feet and legs, sort of also got dead. Is that something that you have heard doctors using in Massachusetts that thought there might be a relationship between her scleroderma and her additional diagnosis? Or in your experience, is that something that you
I've seen it a few times, and it's a known association that there can be what we call an overlap scenario, whereby the patient has one autoimmune disease and then another one chooses to partner along with it. Some of the more characteristic ones are scleroderma and the partnership with Sjogren's. Another one is scleroderma and a partnership with rheumatoid arthritis. A far less common one is scleroderma with vasculitis. But it highlights, and not knowing your mom's case, and I hope she does well, of course, is the symptoms of neuropathic pain could be related to diabetic neuropathy, could be related to lead toxicity, could be related to back problem. And we would never want to assume that, you have numbness and tingling. Well, of course you do. You have scleroderma. No, that's exactly what we don't want to do. Right? Patients who have now new onset numbness, tingling, deserve the same thorough evaluation as anybody else who gets new onset numbness and tingling. And most of the time it's not related. But there are cases that vasculitis can be presenting with numbness and tingling. Everybody who is having numbness and tingling does not have vasculitis, so I don't want to cause alarm. I would just say it deserves evaluation. Specifically to your question, yes, there are linkages between a lot of our autoimmune diseases, and vasculitis rarely can be seen in scleroderma patients. And it's not a simple diagnosis. Sometimes it's a biopsy, sometimes it's a specific antibody panel, but definitely a thorough evaluation. We're keeping you here till 3:30. Do you have any more questions?
6 more minutes.
Yeah, totally kidding.
I was just going to say, timekeeper says there's 5 minutes left. So can you just leave us with, maybe on a positive note of what's good going on in the research world?
Sure, what's good? So I think there are a lot of, there are reasons for optimism for a couple of reasons. I mean, so number one is what you saw today, I hope, is that you have a group of providers who really have no business interacting in any way based on how we were trained, and now we've all kind of come together around a rare disease state. And so, one of the reasons for optimism from a clinical care perspective is that you've seen a nutritionist, a pulmonary hypertension specialist, a rheumatologist, a psychologist, right? A gastroenterologist, all kind of working together. So I think from a team-oriented approach, that should lend to some degree of optimism. Other areas of optimism relate to novel therapeutic approaches. So we have a few patients, and I didn't mean to not give credit to Ken, because Ken's here as well. We have a couple of patients who've gone through a bone marrow transplant, and we have another one on their way for a bone marrow transplant, maybe another one who also may go. So I think the idea of bone marrow transplant, stem cell transplant, and its promise is there is room for optimism that with such radical approaches to treatment, there can be radically improved patient care outcomes. From a clinical trials perspective, the excitement in scleroderma has been mostly about pulmonary hypertension treatment because there are 15 and more FDA-approved, proven therapies for pulmonary arterial hypertension. That has led, without question, such optimism for patients with PAH because as opposed to the average survival being 2-3 years, patients are living 15, 20, 30 years with what used to be without question, uniformly fatal complication. So there has to be an emphasis on PAH detection because we now have new therapies. 20 years ago, we couldn't say that. Pulmonary fibrosis is the next frontier. We now have 2 FDA-approved therapies for pulmonary fibrosis, and they're both being introduced into scleroderma patient populations. And we've completed the scleroderma lung study 2, which showed that CellCept and Cytoxan are both effective therapies. So we have some reason and some room for optimism with those lung complications. Where are we really messing up? Why do patients get this disease? We don't really know. How do we do better with skin treatment? We're learning. Bone marrow transplant is probably our best therapy from the standpoint of really improving the skin, but we should hold promise that mycophenolate, cyclophosphamide, pirfenidone, nintedanib may be good therapeutic options as well. The gut has been more challenging. Digital ulcers have been more challenging. I learned from a doctor who's got a few more gray hairs than I have, which is that there's always room for optimism. Right? There's always room to have hope, and there's always room to think that the future will provide better answers, better understanding of the disease. And so I think your point of ending on positive is well taken. And so the idea of trying to strive for better care, better research, better education, better multidisciplinary involvement, I think is something that I want to certainly end a positive note about. Amy had a question.
What do you recommend if you don't have doctors on the city campus? You've seen different doctors in different places, how best to get them to communicate in case there's something that anybody who's got someone for themselves?
So, it's hard. I'll defend the healthcare provider first. I mean, sometimes, sometimes it's, you don't know the other docs. You don't really know where they're coming from. You don't know them personally. I always find that to be a challenge, right? The doc doesn't know me, I don't know them. So there can be challenges there. Patients, of course, want to know that they're going to be, the center of these multidisciplinary conversations, and you all deserve to be. Candidly, they don't really happen in the real world that often. What I learned from my time at National Jewish is that, when you work down the hall from somebody, it's a lot easier. When I can bump into Kristin at the water fountain and say, hey, Kristin, I'm sending you somebody, can you, and then you share your perspective, that's a lot easier than me trying to track somebody down by an email or a phone or a pager. So the idea of us bumping into each other is great. When it doesn't happen, we have to go the extra mile to try to do that. What can the patient do? Be a really good record keeper. Bring notes to your visits so that I do know what the echocardiogram showed. Not that it was okay. Bring me the note from your dermatologist or from a mental health provider, that you printed out because you access your chart electronically so that you become your own advocate. We try to build multidisciplinary teams. I mean, without disparaging any one institution, that's one of the reasons I moved here. I wanted the biggest multidisciplinary team I could find. So that's what we try to do on our end. Patients can advocate for themselves, but I recognize that can be difficult. Yeah.
I have ologists of the yin-yang. Here are all the people who see me medically. I have these printed off. When I go see a doctor, I say, who is on your system? And they mark them. Then I say, who is not on your system? And I highlight it in yellow. Then I ask them, who is your techie? Who sees that these things are interchanged? So if I see my pulmonologist who's not the CV, whatever his report is goes to CU, goes to all the other doctors. And it has made a huge difference. And all you have to see is that lovely young woman who's at the front desk because she's got the computer. She knows how to use it and she has the time and she stands this. And so get a complete list of who they are, their addresses, their fax numbers, their phone numbers, their emails, and give it to each of those people as you enter, so that I see my pulmonologist tomorrow or a week from tomorrow, his report will go to all my other ologists.
Last question, I think, and we'll call it. Yep.
And it's more of a statement. I'm on the IT side of the medical industry. And so what I've done is I've literally made sure 2 million electronic medical systems at scale health here at the University of Colorado. Whenever I go anywhere, I've got a backup business card from Dr. Kilbourn personally. I have them send the results to you. And then if I have maybe an MRI or CT scan or whatever, I actually get that on this. And I do carry it over here, but I also have it stored in the system. But I think, unfortunately, with the day and age, well, I should say unfortunately, with the electronic day and age, and they are actually causing each medical facility to get on some type of electronic And it makes it nice to be able to carry those records from one system to another so that you can ensure that everybody has the information. Unfortunately, it's a game that we have to do, but at least they're able to do it more easily than faxing and paper writing.
Thank you, Dr. Fischer and Dr. Kilbourn, and thank you to all the doctors today, not just for their participation today, but for all that they do for the Scleroderma Foundation and for all of you. It means a lot to me, having lost my mother to scleroderma, and I consider all of you my family, and I'm so happy to work with all of you. You don't know how much you inspire me on a daily basis, and I love you all. So on that note, thank you all for coming today. Those of you that hung out to the bitter end, way to go.